It's a phrase many clinicians have heard. Hyponatremia is not a sodium problem, it's a water problem. This simple statement unlocks a complex and often misunderstood condition. Paradoxically, a patient with profoundly low sodium levels caused by a reversible factor, like a thiazide diuretic, can actually have a better outcome than someone with only mild hyponatremia that stems from a severe underlying condition like cirrhosis or heart failure. The key is understanding how the body is managing its water balance. To truly grasp this, we must first appreciate the kidney. The kidney is exceptionally skilled at retaining sodium, a trait developed over millennia in a sodium-poor environment. A random urine sodium measurement gives us a powerful indirect window into this process. A low urine sodium, for example less than 25 milliequivalents per liter, strongly suggests the kidneys are holding on to sodium because they perceive a drop in volume. This physiological signal is often more accurate than a physical exam, especially in those ambiguous cases between normal and mildly low volume. A higher urine sodium, on the other hand, implies the body does not perceive a volume deficit, as long as the patient isn't on diuretics. This brings us to the different types of hyponatremia. In cases of hypovolemic hyponatremia, the patient has lost salt through processes like vomiting or diarrhea, and has often increased their free water intake due to thirst. The body, in its wisdom, prioritizes perfusion over tonicity. It releases antidiuretic hormone, or ADH, to retain this free water and maintain blood pressure. The fix here is logical. Giving isotonic fluid increases the intravascular volume, which turns off the ADH signal and allows the kidneys to finally excrete the excess free water the patient consumed. The situation is different in hypervolemic states, like heart failure or cirrhosis, where there's often third spacing of fluid. Here, a low effective circulating volume is the problem. This reduces perfusion to the kidneys and impairs their ability to generate free water. In these cases, loop diuretics are the answer. They work by increasing the delivery of fluid to the diluting segments of the nephron, which promotes the excretion of free water. Perhaps the most common cause of euvolemic hyponatremia is the syndrome of inappropriate antidiuretic hormone, or SIADH. In this condition, the body produces ADH inappropriately, meaning it isn't responding to normal physiological cues. Because ADH is chronically on, the body simply can't get rid of the normal amount of free water it takes in throughout the day. The solution here isn't just about restricting water, it's about introducing more solute into the system. This solute functionally drags extra water out with it in the urine, forcing the kidney to produce a higher minimum urine volume even with high ADH levels. This is where a common treatment myth needs to be addressed. Salt tablets are often a surprisingly bad treatment for SIADH. By increasing thirst, salt tablets can paradoxically cause the patient to drink more water. If this new fluid intake exceeds the extra urine volume created by the salt, the hyponatremia can actually get worse. It's also a matter of dosage. Normal dietary sodium intake, around 100 millimoles per day, already contains about twice as much sodium as typical salt tablet doses. A much safer and more effective alternative for chronic SIADH is urea, typically at a dose of 30 to 60 grams per day. To achieve the same osmotic effect as just 30 grams of urea, a patient would need to take 15 grams of sodium chloride daily, an amount far above any standard salt tablet regimen. In the acute setting, managing severe, symptomatic SIADH requires careful thought. While medications called vaptans can work, they carry a risk of rapid overcorrection. A safer and more predictable option is hypertonic saline. It's important to understand that it works not by directly adding sodium to the body, but by acting as an osmotic diuretic. The administered salt load is excreted in a fixed, concentrated urine volume, which obligates the excretion of free water, just like urea does. This leads to a final, critical point and a common pitfall, known as desalination. This occurs when a patient with unrecognized SIADH is mistakenly treated for hypovolemia with normal saline. Because their ADH is constantly on, the kidneys will excrete the administered salt load in a volume of urine that is smaller than the volume of saline that was infused. The result is the net retention of free water and a paradoxical and often confusing worsening of the hyponatremia. This scenario highlights why understanding the underlying physiology is absolutely essential for safe and effective management.